Good afternoon or evening, everyone, depending on where you're tuning in from. I'm Dr. Soania Mathur, family physician, and someone who has been living with the challenges of Parkinson's for over 25 years. It's a true privilege and pleasure to be your moderator for this webinar. Just as a point of reference, in case you have any questions, there's a Q&A button on your screen where you can type your questions, and if there's any time at the end, we will try our best to answer them. As you may know, International Women's Day is coming up on March 8th. The theme for this year's campaign is to inspire inclusion. The question that they propose is, when women aren't present, we must ask, if not, why not? And charge us all with the action point that when the treatment of women is not equitable, we must take action. Leading up to this day of global activism, our discussion today will focus on women and Parkinson's disease, specifically addressing sex and gender gaps in research and the importance of including women in this process. Joining us to explore this topic today is our esteemed panel of experts. Rochelle Flanagan is a registered dietitian in Ireland, lives with Parkinson's, having been diagnosed 7 years ago. She's also co-founder of the Women's Parkinson's Project and My Moves Matter, a self-management digital app for PD. Welcome, Rochelle. Dr. Carly Tanner is a professor of neurology at the University of California. She's co-principal investigator of the PPMI project and principal investigator of Fox Insight. Welcome, Dr. Tanner. Also with us today is Dr. Elena Moreau, professor of neurology at the Faculty of Medicine at Grenoble-Alpes University in France. She also serves as president of the European Academy of Neurology, where she also chairs the task force on gender and diversity issues. A warm welcome to you as well, Dr. Moreau. And lastly, I'm happy to introduce Dr. Anneliane Oosterbaan, Parkinson's advocate, gynecologist, and researcher from Rotterdam in the Netherlands, who has a keen interest in how women's health may impact Parkinson's. We may have a couple of surprise guests later, but welcome everyone. I'm really impressed and excited by the breadth of expertise we have gathered here today. Before we dive in, let's just put things in perspective. As you all know, PD is often thought of as a disease affecting a specific demographic, that is, older white men. And this stereotype is reflected in the long-standing illustration of the stooped elderly man that dominates medical media. But that understanding is changing. There really is increased awareness and importance being given to sex and gender differences that exist. As an aside, we define sex as the biological origin of men and women based on chromosomal differences, which determines the physiological processes that happen in our body and the organs that we have. Gender, on the other hand, describes the self-representation, social and cultural views of sex, socially constructed ideas, behaviors, expressions, identities. What we're going to talk about mostly today is the importance of research directed towards and attention given to sex differences in particular. And as women, even though we represent close to half the population, we're not always represented in many different areas. For example, what is relevant for today's discussion, clinical trials have not adequately enrolled women or analyzed sex-specific differences in the data. We must ask, as I just mentioned, why not? And also, why is this important? Why is it important to include women in PD research? And if it is important, what can we do about it? So let's start off with what are the differences that distinguish a woman's experience with PD compared to their male counterparts? Where do our current knowledge gaps lie? Dr. Tanner, I hope you don't mind, we'd like to start with you. We know that sex differences can be observed in various diseases in terms of prevalence, risk factors, diagnosis, manifestation of disease, and outcomes. What are some of the differences that we see in PD when we compare men and women?
Well, I'll be happy to answer that question, but I think I want to start by just following along with what you said, that part of what I think all of us are going to be saying today is going to be based on relatively little systematically collected information, because there's been such a paucity of really, focused research in terms of any aspect related to sex or women, or, sex as a biologic factor, or women and their experiences in PD. So I wanted to preface my remarks with that, because I think that there are many things that may have been published that with further study might be understood a little bit differently or more completely. So I think the biggest take home from today is there's a big gap and we have a lot of work to do to try to understand more. So that said, from a population perspective, most studies have found that men are more likely to develop Parkinson's than women. And so the range is somewhere between 1.5 to 1, so maybe a 50% increase in men to as much as 3 to 1. There are a lot of caveats to that because these studies are based on populations where there may have been differences in access to care. There may have been differences in health professionals' approaches to diagnosis in men versus women. And there may have been differences that are true biologic differences that relate to what people do, right? So some of the things we know are that there may be risk factors that are related to occupation, for example, that may differ between men and women. There may be risk factors that relate to behaviors, such as in the past, especially smoking, that differ between men and women. So these are all questions that are important ones. I also would like to point out that some of the early work that has been done looking at risk factors were done in cohorts that were set up in the middle 60s that were only men. And women weren't studied at all because it didn't really matter, right? Theoretically, right? So all of these, I think, are really important things to take into account. When you look at, as we know, a small proportion of people with Parkinson's have a strongly associated genetic component. And in general, when you look at that population, which more younger age at onset than older in general, there may be fewer differences between men and women, even in the population study. So about equal numbers of men and women. There are also sort of changing patterns over time, and exactly the reasons for this, I think, needs to be understood. So this is a big clue and something we need to look at. I'll sort of pass to other people on the panel to talk about some of the other characteristics, and I'll be happy to comment too, but I don't want to take the whole stage. But, in terms of response to therapy, progression of disease, risk factors for developing things like cognitive decline, wearing off of benefit, all of that is also, I think, important to consider.
Absolutely. I think you're right. It's the clinical presentations or manifestations of the disease that actually I didn't realize, but once I started researching and talking about it, it really became much more apparent that our experience can really be different than our male counterparts. Rochelle, did you want to, or Annalene, did you want to talk about that at all in terms of the differences between men and women, or Dr. Moreau? Who would like to take that?
I don't know if I can also ask Caroline about now the environment, right, is coming up with, for example, the pesticides, the role of the pesticides. And do you think that men usually they should be a little more exposed as farmers to the pesticides in the past, right? Because we know that the disease starts a lot of time before the diagnosis. Do you think that also the environment has a specific role in gender and sex differences?
I think that's a possibility, and I think it needs to be explored more completely. So certain occupations like being a pesticide applicator, being in a job where you use chlorinated solvents, some of the compounds that are associated with Parkinson's risk, at least in the past, traditionally have been more commonly occupations assigned to men that men did. That may be changing. And I think, a really important question is to look at that pattern and see if there are differences related to vulnerability that relate to being male or female. I do think there are probably other factors. We know that people who, for example, in some work I did, people who use protective garments are at lower risk, even if they mix or apply pesticides, for example. Certain dietary characteristics can lower your risk of, developing Parkinson's, even if you mix or apply pesticides. So I think it's very complicated, and we haven't explicitly said it yet, but I think, the question of female sex hormones and how that influences things, as well as other kinds of metabolic differences between men and women are important as well.
It's actually a very interesting area of study, for sure. I mean, when we're talking about the manifestations, just to go back to that, we do know that men and women do differ a little bit. And women seem to have more tremor, more dyskinesia, more restless leg syndrome, mood and sleep disturbances, anxiety, depression, fatigue, and apathy and pain seem to be more prevalent in women. But Rochelle, I think from our personal experience, most of us understand that each of us is really unique in terms of what our manifestations are and also which medications and what dose seems to work for us. We all compare it usually when we get together, but we also never seem to have be on the same regimen. So if we generalize, what do we know about the differences between men and women? Is there, in terms of treatment and how the medications work, is there a difference in fact, and how so?
That over to me. So yeah, I mean, I suppose one of the things that I suppose, as you say, often we're on different drugs, but in a way, say with levodopa, you know, it's the same, you know, 25/100, 3 times a day, whether you're, you know, my weight and height versus a man who's, you know, 100 kilos. And so there's a question, you know, is there a difference in terms of how we respond to the medications? So I actually have a few slides that I was going to prepare to go through, and maybe it might just prompt a bit of discussion, if that's okay.
That'd be great. Thank you.
So just you can see that okay? So yeah, so just looking at some of the research, so we know in terms of, you know, other conditions like heart disease, that women actually absorb the medications differently. And you know, so we're beginning to see this in Parkinson's as well. So the reality is that there was no double-blind placebo-controlled study of levodopa performed before its approval. So we don't have any kind of, you know, benchmark, I suppose. But there's a couple of studies which are referenced at the bottom that show that sex differences in pharmacokinetics, so that's basically in terms of the absorption of the drug, strongly predict sex-specific adverse reactions for women, but not men. And this sex difference apparently was not necessarily explained, you know, by weight alone. And one of the authors of one of the papers suggests that women might actually require 25% reduced weight levodopa dose comparison to men to achieve the same bioavailability. And that would help maybe towards minimizing the development of dyskinesias in the long term. Also, they suggested that adjusting plasma levodopa by BMI showed the most relevant kind of differences in pharmacokinetics based on gender. And BMI more than body weight, they recommend maybe actually the best personalized approach to actually tailoring medication for women. The other thing is that research shows that women have about 25% lower COMT enzyme activity than men. So that apparently can feed into the differences in terms of response to medication. And also they have to take into account that levodopa with benzodiazepines, as they instead of carbidopa, actually, you know, means that you absorb the medication, the levodopa, more than the levodopa carbidopa. So that possibly would feed into issues in terms of women developing more dyskinesias. And I suppose that brings me on to this slide, which talks about the gender effect has been shown for occurrence of levodopa-induced dyskinesias and occur more frequently in women after a 5-year duration. And I've seen myself as a dietitian, heard many women talk about, you know, their dyskinesias, and I'd ask them, I'd say, have you lost weight? And they have often lost weight. And obviously with the dyskinesias, you lose weight. And then often what happens is they might be prescribed more levodopa, and that just kind of feeds into this kind of vicious cycle of dyskinesia, weight loss, and you know, worsening. And in terms of factors that impact women's sort of absorption, things like renal clearance of the drugs is decreased because of women's lower glomerular GFR rate of their kidneys. Slower gastric emptying is another impact on medication. In terms of they have lower gastric pH, lower plasma volume, often a lower BMI, lower organ blood flow, total body water differences are different. So all of these affect drug distribution and pharmacokinetics. And also the response to drugs are often affected by the physiological changes in the menstrual cycle. So there are many factors that could be addressed in terms of planning care for management of women with Parkinson's. And then just in terms of wearing off is reported to be higher in women, that they suffer from it more often than men, and that their gender increases the risk of wearing off by up to 80%. And in this particular paper, it's called a D paper back in 2015, they sort of, state that, that gender differences are generally not acknowledged in published clinical guidelines in Parkinson's management. And the evidence of gender disparities in medication response, pharmacokinetics, and tolerability, which suggests that we need to pay more attention to the differences. And also think very importantly from a research perspective, that they sort of state that the risk of generalizing data derived from trials, is something that needs to be considered. So the gender effect should be considered carefully in designing clinical studies for Parkinson's. And just another offshoot of that was they mentioned that women suffer from more of the non-motor sort of mood symptoms, and that this, actually led to the women having more likely to be prescribed with antidepressants, antipsychotics, etc., rather than getting levodopa earlier. So men tend to get prescribed levodopa quicker than the men did. That was in this particular study. So there are a number of things that need to be looked at in terms of, because dyskinesia is very disruptive, and wearing off both impact quality of life. And again, that's shown in the research when they do look specifically, both at men and women, but women in particular. So I'll just stop there. Those slides.
Thank you. Thank you, Rochelle, for sharing that with us. And Dr. Moreau, so as we saw from Rochelle's presentation, there seems to be a lot of differences when it comes to patient outcomes or responses to treatment between men and women. How does this impact the research that's been done and also the clinical management? Because a lot of our medications that we get now have probably been done in research studies in the past that may not have taken into consideration the sex difference. So how do you feel this will impact research now and in the future, and the clinical consequences of that research?
Soana, so thank you, Rochelle, because you presented very well the most relevant difference. And as you said, the research is very poor, because this paper, they are dealing with a very small number of people. They don't differentiate even for age. And as you said, the fertility of women at the time. So it's very difficult to draw conclusion. And if I might to add, there are also genetic problems. Women, they have more predisposition to develop dyskinesia because the receptors of drugs are different. So it's much more complicated than what we think. And for these reasons, the guidelines, when we prescribe a medication, we usually follow guidelines, and they don't talk about these differences. They don't talk about weight. So like the pediatrician, they used to measure drugs according to the kilos, right, or the pounds. In adult neurologists, they just prescribe milligrams, and they don't even think about the weight or the sex and the gender, as we discuss. But we know, as we said, that women, they have more dyskinesia, they are more wearing off. So we should stop, right? Just saying, follow the guidelines because you have all these algorithms. We should personalize according to what we said, to be careful to give less levodopa, maybe this 20–25%. And so we need more research, but also it's not only levodopa that we are using. We are using dopamine agonists. And guess what? Dopamine agonists, there's no papers about dosage. We know that the side effects are different between women and men. Men, they develop more hypersexuality, gambling things. Women, they're more, buying things, more eating disorders. So, but nobody's asking why we have these differences, just because women usually, they like buying things. Well, men can also buy cars and other very different things. So just to say that, as also Carly said, we are at the beginning. right? A beginning of new chapters in which, if we want to personalize and have the most relevant effects without side effects, we need to understand why we develop these side effects and how we can avoid not only the dosage, but differences in the molecules that we need to find better in preclinical, probably, research as well.
That's actually very interesting. And you're right. I think it is the beginning of a new chapter. But for women that are listening, that are patients, is this something that they can feel comfortable bringing up with their movement disorder specialist in order to discuss? Is this sort of information being permeated through the neurological community as well?
I think yes, definitely. So, neurologists were always in a hurry, but I think we have to remember that we have people in front of us, people who are different for many reasons. So is sex, gender, and diversity, the social background that we have to take in consideration. And as also Richelle said, the stigmas, right? Oh, it's a woman, so she's anxious. Well, not. This is a special non-motor part of Parkinson, which is more frequent in men compared to women. It's not because women are hysterical or anxious. This is a different side of the disease. So we have to treat that maybe in not non-pharmacological with other multidisciplinary approach. But we have to stop thinking now that women just, they complain about pain because they are just women. Pain is another big problem in Parkinson's disease, and it belongs more to women compared to men. So women have to speak up.
We have to advocate for ourselves sometimes.
Yes.
That's important. So from what has been discussed, we can see there are really unique challenges that women face, such as how the disease presents, the motor and non-motor issues that women face. And studies have shown actually a diagnosis that women tend to have a poorer health-related quality of life, more psychological distress, and self-reported disability. And what's more, we hear from our community that the severity and impact of these symptoms will vary according to the hormonal status of women. I've experienced it myself. So for example, throughout the menstrual cycle and during and after menopause. But there's, as was already mentioned, there's simply not enough information and so many questions remain. And Liliane, as a gynecologist, your expertise lies in following women all through their life stages and in that milieu of hormonal changes that occur premenopausal, through a pregnancy, post-menopause. What do we know about how these different stages and hormonal imbalances, how do they affect Parkinson's symptoms and treatments?
Well, we don't know that much about it, but I've prepared also a little presentation, so that maybe I can start with my slides. Is that a good idea? Wait. Share. Can you see it? Yeah, I think so. Do you see it properly?
Yes.
Yes. Okay. Yes, I wanted to talk to you about the hormonal impact of Parkinson's disease in women. And well, here you see myself and also Wilanka Capelle, and she's a PhD student on the project. And together we will be the principal investigators in the future for the Women and Parkinson's research team at the Radboud, because we will never stop doing research until everyone knows about this topic. So, and we know more, of course, because being a woman living with Parkinson's disease is just really difficult, because it's just a diagnosis she cannot really identify with due to stigma. And that's also why we wrote the booklet In Her Shoes, of course, for all women to read at www.yopdwomen.com. Because we need to get rid of the image, this ancient image of this pale looking old man. So bam, there he goes. Because to me, as a gynecologist and a young woman, it's just so clear and logical that there is a cyclic pattern in PD symptoms. We all suffer from a cyclic pattern in just normal symptoms like PMS. But being a woman with PD, you can just imagine this is terrible. It must have impact, and it's just unclear to me why this just hasn't been a topic of research before, but happy that it's on the map finally. because as women, we are just very beautiful and interesting creatures. And in the past, we have been neglected in research because we are difficult, but these hormonal fluctuations are actually really interesting. And here you see different hormonal life phases of a woman. And it also contains pregnancy. And of course, this all impacts our Parkinson's disease symptoms and effectivity of our medication. Because even when you have a flu or just, a cough, everything physical impacts our Parkinson's disease. So of course, this also has impact, and it has huge impact. Well, 2 years ago, I was pregnant myself with Parkinson's disease. And of course, being a doctor, I looked through the whole internet, and I couldn't find proper information to reassure myself that this would be a successful project. But still, I decided to, trial and error, become pregnant and change some medication, started on levodopa only because that was the only advice I could find. But it was still quite an anxious decision because I wasn't sure whether it was safe or not. And well, eventually it all turned out great, but I want other women in the future to be able to make an informed choice. So that's why we launched PragSpark, the registry for pregnancy and Parkinson's disease. Any woman in the world living with Parkinson's disease and who's pregnant can join at www.pragspark.com. And here you see the study flow that we've designed. So women can enroll up to latest 8 weeks postpartum, and they get different questionnaires at certain time points. So please spread the word, because we can only write guidelines and management protocols when we have enough information. We also performed a survey study in the Netherlands that was finished the end of last year, and the manuscript is on the way. It contained all women in the Netherlands, or women between 21 and 60 years old with a diagnosis of Parkinson's disease, and we wanted to explore the hormonal impact. And eventually we included 110 women, and the average age of the women in the survey was 51, and the average age of Parkinson's diagnosed 45. So they were all approximately 6 years living with Parkinson's disease. And we were interested in all these hormonal life stages. And the most important message is that at least 2/3 of the women experienced worsening of symptoms around their menstruation, and most of them, it was a couple of days before the period started. They had an increased lack of energy, irritability, wearing off, rigidity. The medication just doesn't work properly. And well, almost none of these women has been given proper advice or what to do about it. One woman was referred to a gynecologist to talk about this. Also, menopause, like more than 2/3 of women experience worsening of her symptoms through menopause. Also logical to me. These are some of the other questions we asked about their relationship status. I think also striking is that like 42% the diagnosis influence their self-image in a negative way, women feeling less confident, of course. And you can imagine, due to most of the times these symptoms were mentioned. And also we asked about engagement of women in research, because of course that would change the future. Women should participate in research much more. They previously participated, half of the women, but they almost all would do it again in the future, would join the research in the future. So that's hope for the future. And I think also really important for the future is that we need to improve care. We need to make it really personal. And I think, this is my dream center with a personal Parkinson's coach in the middle. And it contains lots of things. And of course, you need the physician with some medication, but it's only a small portion of the care we need. And for women, I think it's important. We also have a combined consultation of a neurologist and a gynecologist. We've made it happen in the Radboud already, so women are welcome to see a combined consultation. We're really happy with it. We've already seen many women. So yeah, the hormonal impact is significant. I experience it myself every month. It's really terrible. I think we should tackle it with hormones and not only with Parkinson's medication, but we will have to try it out in clinical trials in the future. And we will just continue doing research until we have answers. I think that's the most important thing I wanted to share with you.
Thank you so much. And Leanna, I was actually expecting my first child when I was diagnosed, and then went on to have 2 more. And every time was a different experience. Sometimes they were concerned, sometimes they were over concerned, sometimes they were not concerned. So the research that you're doing, I wish it had been there before, because it might have actually given me answers. I was flying blind 25 years ago, that's for sure. And so do you also foresee in your kind of dream scenario, women changing their medication dosages depending on the time of the month they are, or postmenopausal? Do you think that those are factors that we should be looking at from a research perspective?
Yes, I think that all has impact. And yeah, I myself, I'm a mediflexer. That's how I call myself. I change all the time, also in a cyclic pattern, because the days before my menstruation, I just need more levodopa. I cut the periods in between the pills, and I play with it. But I'm a doctor, so I can, but not all women try this out themselves. But I think that's the future. You need a personal plan, and but we just don't know what is effective, but it will be different for everyone. It's just personalized care, and for women it's even more complex, but we will find answers.
You're right. And I guess from a safety perspective, if women are thinking that they need a change of medication, they should obviously
discuss with their doctor.
Their doctor before doing anything like that.
Yes.
Thank you so much. Rochelle, you've also been working really hard in this space, advocating for more understanding of how PD affects women in particular. Could you please share with us? I think you have a few slides of some of the work that you've been involved with, or that you
Absolutely. I just want to say it's quite interesting that the 3 of us all were pregnant. My Parkinson's I picked it up when I was 3 months pregnant. So there's definitely something in terms of, anecdotally, I know a lot of women with Parkinson's, young onset, it has been triggered around the pregnancy. And I think it's quite interesting, just throwing it out there. When I was pregnant with my first child, I actually was diagnosed celiac after it. And it's quite common after a pregnancy that you would develop underactive thyroid, or celiac can be triggered as well. And then interestingly enough, after my second pregnancy, my Parkinson's was diagnosed, or in and around it. That I wonder, is that there an inflammatory process that's going on, that, and the hormones, around pregnancy are such an immunological sort of, rush, pregnancy, that I wonder, is it something that we should be looking into? So that's just a thought there. So yeah, I suppose in terms of just exactly as Anne said, after my daughter was born, I went back to normal menstruating. I noticed that my Parkinson's symptoms got worse around my menstrual cycle, and I noticed some of my friends that I met at the WPC and through social media groups. I mean, there's not a day that you don't see someone asking a question, or do you notice your Parkinson's symptoms getting worse around your menstrual cycle? So this, I'm just going to share then the slides, kind of led us to doing some survey like then. I'm just going to this up again. You see it there? So basically you'll see there that so in the survey we did, and this was just, we did it on SurveyMonkey, it's 240 women around the world through the PD Avengers. We disseminated it, and 86% said that their Parkinson's symptoms are worse the week before, 49% during their period, and 9% after their period. This was then further corroborated by the Fox Insight survey, which we were very grateful for them putting up the survey, and it showed that actually 44% of the women indicated that their medication was less effective the week prior to their period, 30% during a period and 3% after, which to my mind seems to indicate that so basically before your period, your estrogen and your progesterone drop, and then obviously start to come back up as you kind of go through your period and out past your period. So it definitely seems to indicate that there's some interaction going on. And we know that the brain contains estrogen receptors and that is somehow interacting with the estrogen. But actually progesterone seems to be playing potentially, everyone's focused on estrogen, but I think progesterone has a role in that as well. And then also there was a group in the Val Hebron group did a study, similar, repeated this sort of survey as well, and showed that 38% indicated less effectiveness of their medication. So that's like really, it is very serious for those of us living with Parkinson's, especially, you're working, you have kids. I have women who've contacted me who literally are, have to give up work or out of work for, so it's 1 to 2 weeks, every month whilst you're living with Parkinson's, bad enough as it is, like getting an extra whammy for those 2 extra weeks. And then in terms of the, that's kind of the retrospective, the surveys. But in terms of kind of prospective evidence out there, so there was an abstract that was published at the MDS Congress last year, showing that they tracked women and whilst they went through their menstrual cycles, and ultimately the results confirmed that the role of estrogen in dopaminergic pathways and the abrupt reduction of estrogen levels during the premenstrual period may contribute to the responsiveness of the dopaminergic treatment. So I think there's a lot of, small evidence, but it's, we need to do, more research on this. And that's what brings me on to delighted to share with you that we actually, from the paper that we wrote with Indu Subramanian and Professor Elena Morrow and Dr. Keener, one of the things we highlighted was that, women are suffering these symptoms but have no way to actually advocate for themselves or to report this information. So they have to kind of justify themselves. So it was suggested that some ways of tracking would help them to do that. So alongside that, we thought it would be good to actually, do a prospective pilot study where we'd ask women who are still menstruating to track their Parkinson's symptoms across their menstrual cycle, so that we can actually get sort of the real world evidence that this is actually, happening, and corroborates with the survey responses. And also just delighted to announce that we've actually extended this out now to women in the States, and also we're looking for women who are not menstruating or have less regular menstruation, erratic periods. So perimenopausal, often, periods are more erratic. Even when you're menopausal, you can still have some spotting your periods. Women who are pregnant and postmenopausal women, because we want to look at the sort of different life stages and see how does that compare to the premenstrual or pre-menopause women. So we're looking for 200 women who are menstruating, but also we want a lot of women, as I say, who are in other stages of life as well. So you can scan this QR code on the screen if you like, or you can click on the link, and I think Helen Matthews in the background is going to put that in the Q&A or the chat. So that study is launched in January, and it'll be a rolling study, and we're asking women to track for 4 months. And basically, as we want to see as you go through each month, and because women's menstrual cycle is sort of erratic, we need a number of months so that we can actually see if there is a pattern there. And then also, I'm delighted to announce that we're also collaborating, just to mention that we'll be using the My Moves Matter app, which allows women to track their symptoms, their medication, and their periods. And in the background, we have a database, and the information is anonymous in this particular trial. And UCC are our partners. It's Professor Aideen Sullivan, who is due to be on the webinar tonight, but due to personal circumstances couldn't attend. And also her post-fellow doctor, Lucy, is also, Colin Stack is leading the charge on this for us from UCC, University College Cork. So it's really exciting that this is happening. And then also delighted to announce that alongside Professor Elena Morrow, we're actually going to do another study thanks to a grant that we won through France Parkinson. And basically what's going to happen is it's going to be a 4-centered study in France, looking at women who are menstruating, women with Parkinson's who are still menstruating. And we're going to have 2 phases. So one is they're going to track. It's not going to be anonymous because they're going to actually be in with their neurologist. They'll be assessed before they start tracking. And then the women who have report that their symptoms are worse are actually going to see their neurologist again and get an intervention. And just in terms of that discussion about what the interventions are, we know at the moment out there that women are either given extra levodopa or they're given the oral contraceptive pill without a break. Because obviously when you have a break in the oral contraceptive pill, you basically, your hormones drop and that affects your symptoms. So we know anecdotally some women are put on the oral contraceptive without a break and that improves their symptoms. But there's a whole issue around all the different, it's not just the pill that women use, they use all sorts of IUDs, etc. And they all have different combinations of hormones. So as Anne said, it's a complicated process, but it's a very interesting one. So this pilot study in France, we hope to be launching in July, August of this year. And then just going on to this sort of perimenopause, there was a small study done by a neurologist in the UK, Eva Bunting, alongside her nurse, Jane Bryant, in their particular clinic that they run. And one of the things that came up was a lot of women, feel confused about the symptoms, because actually the symptoms of menopause are very like Parkinson's symptoms. So that can sort of affect then in terms of their reporting. So in terms of out of their sort of 65 women in their clinic, 33% reported menopausal symptoms, and you'll see the vasomotor symptoms were by far the highest there. And then they were asked, did HRT improve their symptoms? And you'll see a small amount said it was positive. Another amount was unsure, and there was quite a large amount that said that there was no effect. Also, alongside this neurologist survey, I actually ran a survey through Unmet. 178 women responded to this, and we asked some particular questions as well. So they said during perimenopause and menopause, did they notice whether their Parkinson's symptoms are worsening? And 32% said yes, 65% said they're not sure. And there's a question in terms of how many of that 65% actually was that Parkinson's was worsening, but they just didn't know because menopause kind of mixes it all up for us. And then in terms of those women who were if they had taken HRT, did you feel it had a positive effect? And you'll see that 45% said yes, 20% not sure. So again, that could be a larger number that is positive. We need more research. So just in terms of recommendations that came out of that small study was that vasomotor symptoms should be considered in the non-motor symptom questionnaire for women. Neurologists must engage with GPs and gynecologists, like Anne said, to develop evidence-based guidelines with regard to HRT. Research into any neuroprotective benefits of HRT should be looked at around the critical window, because we know in terms of in Alzheimer's, if women take HRT in that critical window, it actually reduces the risk of Alzheimer's and Parkinson's. And also perhaps in view of Parkinson's specific evidence, the neurologists and Parkinson's nurses should maybe use the NICE guidelines with regard to the treatment of menopausal symptoms. Because the reality is, we're women and we're suffering with these, so they need to be taken into account regardless. And I just want to finish by just acknowledging a lot of women who have helped along the road since we did our first Cure Parkinson's webinar way back when, I don't know, 3 or 4 years ago now, to Indu Subramanian, who championed the Unmet Needs paper, and to all the women here, I really thank you, and all the women who took part and will take part in the studies going forward, because without you, we can't get the answers. So that's it, and I suppose it's just really, I think it's about empowering research through inclusion of women. I think we can get more answers, I firmly believe. So I'm just going to leave it there.
Thank you so much, Rochelle. It was very interesting to see that all summarized. I think in terms of those that are listening, the ways that you can help are really to think about joining Fox Insight to access the series of questionnaires that we have right now about women in PD and their experience, as well as looking at and downloading My Moves Matter. This is an easy way to participate in research. It's an easy way to help our general community, and it's actually an interesting procedure to go through, because sometimes you learn a little bit about yourself or some patterns that maybe you didn't recognize before. And those links for both of those, Helen has kindly put in the chat part of this program. So I mean, from what Rochelle told us, it's very clear that there's a lot that we need to know, and there's also a lot that we don't know. And there are potentially many unmet needs that must be addressed when it comes to women in PD. I just want to go back to Dr. Tanner for a moment. Dr. Tanner, how could we ensure that therapeutic clinical trials are inclusive of women with PD and their unique genetics and hormonal status and drug metabolism, so that we have a proactive, like, sex-specific data analysis plan? Like, how do you think that we can do that?
That's right. I think you just said it. We need to have a proactive sex-specific analysis plan that takes into account the specific kinds of questions we want to ask. So the simplest one is, does this treatment affect men and women similarly? That would be question one. And to be able to really answer that question, you're going to need to have enough women in your trial to be able to make a valid comparison between women and men. The problem we have with most of the trials that are reported today is they don't even break down men and women. So you can't even necessarily look at whether or not there appear to be differential responses. When they do, men tend to be overrepresented, even disproportionately, to the fact that more men than women typically have Parkinson's disease in the population. So I think thinking about that carefully is really important. Some of the other things that people have talked about, I think, are also important. When we're doing certain types of trials, like trials looking at motor fluctuations, time of day, time of dose are really important. If you're doing a trial of women, it would probably also be important to know time in the menstrual cycle. Are you pre or post or perimenopausal? Are you taking HRTs? Well, we usually learn that, but we don't usually factor it into our analysis. So I think starting to think about this and thinking about those questions is going to be really important.
Makes good sense. Dr. Moreau, do you have anything you wanted to add to that?
Yeah, I would also like to add non-medical treatment, right? So I don't think there is specific studies about difference in the physiotherapy, right, between women and men. I think the plan should be different, and nobody is studying this. How many times, for example, maybe a woman needs much more. We have osteoporosis also coming up, so which is another big interest in the prevention of complications that are more frequent in women, falls and fracture compared to men. So we, as we said, all the medical devices in advanced treatment of Parkinson's disease. To my knowledge, what I know is there are some disparities in the brain stimulation, but I didn't see anything really in other devices like pumps with the levodopa pumps, apomorphine. The studies are very few. So, and probably we'll discover that is not the same way the results and the side effects in women compared to men.
Thank you. Rochelle and Annalene, you mentioned, I think it was you, Annalene, that mentioned that women are not really engaged in research as much as men. And do we understand why women are not engaged in research, and how can we support the women in our community to become more involved?
Well, I've also asked why they didn't participate in research before. And they answered things like they were too busy with their young families to make time for research. The distance to travel to the research clinic is too much, or they just didn't take the time for themselves. Yeah, because of the jobs and family. How do you say that? Things they needed to do that they just didn't find the time to be in research. But when it would be possible to do it online or from distance, or just not too frequent, then they would, of course, always be interested. But we need to help them a little bit to make it more accessible and easy to join, I think. Yeah.
I suppose I might come in the back of that. I mean, that's why, we're doing the study through the app, because that actually facilitates women to be able to take part in a real world scenario whilst they're working with kids or whatever. Now, obviously, it's only just a tracking, but I think, in time, maybe that, the ideal scenario is that a drug can be delivered to your house and administered by a local community nurse, and you can track on your phone, so you don't have to, because it's a big ask to expect women to take, 6 weeks out of work or to travel in and out of a hospital or whatever. So I think that is a difference between men and women in terms of taking part in research, is they have a whole load of other things, responsibilities that often tend to fall on the woman's shoulders in terms of, coordinating the household or whatever, or just, her own job. So I think that's a really important thing, is trying, as Leanne said, to facilitate easier participation.
Also what the women answered, that even though they had Parkinson's, they still felt more than 50% responsible for the household tasks or taking care of the children. More than 2/3 of 60% of the tasks were still on their hands. So we tend to still take care of others and not take good care of ourselves, and that needs to change.
And could I ask a question in terms of around the hormones, just back to Dr. Tanner, about, knowing about the point of your cycle. So I know, and I put this to a few researchers, that, most women are told when they take part in a clinical intervention that they have to be on the oral contraceptive pill, because obviously to avoid pregnancy. But if a woman is on that, surely that potentially might actually impact the outcome of the study, because we're seeing that the hormones obviously are having some impact on the medication uptake or the effectiveness. So should trials be actually, looking at that and taking it seriously? Because I said it to a few researchers, they're like, oh yeah, that's a fair point. But there hasn't been really much work on it. Is it something that really could be skewing some of the outcomes of studies?
Yeah, no, I think that's a really important question and observation, and obviously we don't know the answer. We have some ideas, as you've just expressed, based on experience outside of clinical trials, but to be able to develop a study that could really explore those questions, I think would be important. And perhaps it might first be something that starts with a more known treatment rather than developing a drug for a new indication for Parkinson's. Just to try to explore that first and understand a little bit better how to go about that.
I think it's important for all women that are included in trials to know whether they still have a regular cycle, or they use what kind of contraceptive they use, or hormones. It's really important. I think it's a never asked question in general trials now, but it's really, it has impact.
Yeah, I don't think that's ever been included. And while we do collect all the other medicines that people are taking in trials, I don't think there's been a specific analysis that's looked at the relationship between any, sex hormone and outcome in a clinical trial of Parkinson's. We did do a study once where we saw people who had early surgical menopause had an earlier or greater risk of developing Parkinson's, but there's been very, very little looking at that explicitly.
But it will impact our well-being or our function.
But what's quite interesting is I looked at that, because when we were doing the application for the France Parkinson's grant study, one of the reviewers came back and said, what about the impact of the hormones? And I was thinking, and I started to look up all the different hormones, and I felt a bit ignorant, to be honest. I didn't realize there were so many, in terms of oral contraceptive pills. There's ones with estrogen only, ones with estrogen and progesterone, and they have different amounts. And then you've got IUDs like the copper, which has no hormones. You've IUDs who just are estrogen. So actually, they're all going to have potentially different impacts, because the two hormones have an impact, it seems. So as you say, it's sort of like, it's mad really to think that 40% of the population are women with Parkinson's, and this fundamental huge part of our life is just ignored. So hopefully, maybe we'll start. We've already started the dial, I think, with some of the studies we're doing. But how do you think we can take that forward in really engaging the community to take this seriously?
Yeah, I think you're right, Rochelle. The more discussions we have, the more questions we unveil, for sure. Just as we come to the end of our time together, I'd like to take that further, what you're asking, Rochelle. I'd like to ask each of our panelists this one final question. If you could just answer in 1 or 2 sentences. I mean, there are likely a variety of listeners today, patients, clinicians, researchers, funders maybe. If you have a couple of action points to help address the inequity that currently exists in research, what would you recommend? How can they help? And we can start with Dr. Tanner, maybe.
I'll start. So if you are a researcher, what I suggest is that you start by paying attention to biological sex and recording data so that we'll be able to do analyses of not just within your study, combined analyses pooling across populations. If you're a woman with Parkinson's, what I would recommend is that you really raise your voice, advocate for more involvement of knowledge in this area, and if you can, that you yourself volunteer for participating in research.
Thank you. Dr. Moreau.
Yeah, so I think we have to teach these medical students, the residents, that they have to be open to gender and sex difference in several neurological diseases. And we are talking about Parkinson's disease. So we have to raise at the educational level this important point. And also, as we said, tell the patients or ask them, and that in their list of questions that usually they ask us, they have to be this specific question about sex and gender inside.
Thank you so much. Annalene.
Yes, yeah, I think we need to educate as well the doctors and the patients and make sure the questions are asked, even though we don't have answers yet. And also, I think there's a gold mine of data already present in all big clinical trials that have been performed up till today. And I think it would be interesting for researchers to have a look into that and to check for sex differences in this already existing data. And for the future, this topic cannot be ignored anymore. I'm happy our manuscript is on the way. It's just there is an hormonal impact, and we need to just dive into it more and more, and I hope many researchers will get along. Join
Thank
us.
you so much. Thank you so much. Rochelle, just a couple of points that you might have.
Yeah, so I've put our website, mywomen'smatter.com. What I'd say is this has been a study that has been driven by women with Parkinson's for women with Parkinson's. So what I'd say is vote with your feet, take part in the study. It's an easy one to do because it's just tracking. There's no major intervention, but it can really potentially lead to us getting some data that we can have larger studies like the one that Professor Elena Muller is going to do, and ultimately lead to clinical guidelines, because ultimately we can't get treated unless we have the research to get the clinical guidelines. So what I just say is please sign up and let us get those answers so that we can start to change the trajectory of care.
Thank you so much. As PD is the fastest growing and second largest neurological condition worldwide, it warrants equality in the study of sex and gender differences. High quality, prospective, longitudinal studies analyzing these differences may identify information that we can use, reliable sex-sensitive biomarkers and social markers that could translate into a more tailored clinical approach for the diagnosis and management of women with PD. And that would lead to improved quality of life for women with PD during any stage of life. That in itself would be great progress for women living with the challenges this disease brings, and actually for everyone facing those challenges. Because the fact of the matter is that research into women's issues will not only benefit women, but will increase our general understanding of the disease. And those insights may indeed benefit the whole Parkinson's community. In fact, the answers to finding better treatments and ultimately a cure for this disease may actually lie in our differences. And I would sincerely like to thank each of our panelists today for sharing your wisdom and knowledge. It's been a great discussion, and my sincerest gratitude to all of those who attended this webinar for taking the time to listen and to learn. So please enjoy the rest of your day, and thanks so very much.